Hello everyone and welcome to part 2 of my EKG review. The learning objectives for this podcast will be to determine how to calculate the axis and if there's any axis deviation, to diagnose any type of conduction blocks, to look at different types of infarction like an ST elevated MI versus ST depression, and finally to look over any abnormalities in the atrium or ventricles. So let's get started first with the axis. And I know this is something that confuses a lot of people, and I'm going to keep it to the bare minimum to hopefully make this as simple as possible. So a lot of these pictures are from the first podcast that I did, but there's some of the more important ones, so I figured I'd include them again. If you look at the picture on the left, this is the normal vector. Hopefully you recognize that. It's moving down and to the left, which is where the left ventricle is. And you can kind of see where that arrow would be pointed in the middle and on the right pictures, how it should be somewhere between 0 and positive 90 degrees. And if you look at the picture furthest on the right, you'll see that that's where the normal axis is. So anytime this vector is shifted to a degree that's not between generally around 0 to positive 90, there's going to be a shift in the axis, and that'll be known as either right axis deviation, left axis deviation, or you can have extreme left or right axis deviation. So when you're looking at an EKG and trying to figure out which way the vector is pointing, that's why it's extremely important to understand which parts of the EKG should be up and which should be down, because if they're different from normal, then you know something is going on and we can start to figure out where the axis might be. So what you want to do is use lead 1 and AVF, because those are the two that look at right to left and up to down. Lead 1 would be left to right. Remember, the positive electrode for lead 1 is on the left shoulder, so depolarization towards the left shoulder would be positive or an upward deflection. So if it's going so if you look in lead 1 and you see a negative deflection for QRS, then you know that it's opposite. So keep that in mind. And then AVF is similar, but now it's up and down. So I broke this into a chart, and I also put a picture of a normal 12-lead EKG and where the depolarization is, and if it's positive or negative deflection. So normal would be it would be upward or positive in lead 1. In lead 2, it's also positive. And I should state that we're looking at the QRS complex right now. So in a normal EKG, lead 1, 2, and AVF are all going to have positive deflections, and that should make sense. And I'm not going to kind of go over that again because I touch on that in the first lecture for a while. So the second thing that can happen would be right axis deviation. So in this case, lead 1 is down, so the opposite, and I kind of explained that before. So if it's going downward, then the depolarization is going away from the positive electrode or towards the right. So that's a hint that it would be right axis deviation. Lead 2 is more looking inferiorly, so that's not going to change, because even if the new vector is to the right, it's still going down, and AVF would be the same. Now if you look at left axis deviation, it's a little bit different. Lead 1 is to the left, so that's going to be positive, but lead 2 and AVF are both inferior. So if that's being pulled upward, then the negative deflection will be seen in 2 and AVF instead of an upward deflection. I know it's a little bit confusing, but if you think about left ventricular hypertrophy maybe as a cause of left axis deviation, then the amount of hypertrophy that the left ventricle experiences actually kind of pulls it posteriorly and upward a little. It's kind of confusing. There's some better pictures you can look at online if you have trouble really thinking about it, but there's a lot of causes of left axis deviation, so don't only think about hypertrophy. There are certain types of like hemiblocks that can cause that. But if you can remember the up and down in 1-2 AVF, then it'll keep it simple. So here are the two examples I didn't include normal axis because all normal EKGs will have a normal axis. So what you want to do is look in one to an AVF, like I said. So the top one would be left axis deviation. If you look in one, there's an upward deflection in the QRS, which is normal. If you look at two, though, the S wave in the QRS complex is more negative than the positive R wave. So you could say that that's quote unquote down. And the same thing is true for AVF, which is down. So we know that this is what left axis deviation would look like. If you look in the bottom EKG, this is an example of right axis deviation. If you look at lead 1, now it's down, which is opposite of the picture above it, and lead 2 is positive, and AVF is also positive. So now we know that this is down but to the right because of lead 1. So that would be right axis deviation. So again, different types of blocks might cause this, or pulmonary hypertension where the pressure in the lungs is high, so the the right ventricle kind of hypertrophies to overcome the pressure required to open the pulmonic valve. So that'll cause a right axis deviation. And that's all I'm really going to say about determining the axis. There's some mathematics that are involved, but I wanted to keep this as simple as possible, so I'm not going to go into that. So the next topic I want to talk about is conduction system and different types of blocks, like AV blocks or bundle branch blocks. So this is also a picture from the first podcast I did, just a review of the conduction system and how depolarization occurs. So SA node to the AV node, and then through the His bundle into the right and left bundles. The left bundle branch is broken into two fascicles, or two sub-branches, you can think of it, the anterior fascicle and the posterior fascicle, and the right bundle is just its own entity all the way down to the Purkinje fibers. So what can happen is you can have a block in the AV node, the His bundle, one of the bundles, the left or the right bundles, or a sub-branch like the fascicles. So if it's a block of everything, you would just call that a left or a right bundle. If it's a fascicle, then it's called a hemiblock. So you can imagine there's a lot of different combinations as to where the blocks can occur, and it gets pretty complicated. But again, I'm keeping this lecture as simple as possible, so I'm only going to talk about AV blocks and left and right bundled blocks. So I'm going to start with the AV nodal blocks. There's three different categories. There's first, second, and third degrees. They're not called categories, they're called degrees. First is just first degree, however second degree has two different categories. I should say that second degrees are also known as Mobitz, so you might hear that thrown around. And Mobitz 1, there's two subtypes. Mobitz 1 is also known as a Wenckebach. So there's a little bit of jargon you have to know for this. You could see it written anyway, either on an exam or in the real world, looking at a cardiologist's note. So there's two types of Mobitz blocks, and then there's a third degree AV block. So, and then I also wrote, think of each degree of block as a worsening of the block. So you'll see that as we move forward. So first degree, it's slowed progression through the AV node, which prolongs the PR interval. Normally it's under 200 milliseconds, which is a big block. So if you see the PR interval is greater than the big block, you know that something's going on, probably some type of AV nodal block. A type 1 second degree, on the other hand, is going to have a progressively slowed conduction through the AV node. So the PR interval is going to progress with each beat of the heart. So really what you have to have is a rhythm strip. If you look at one or two beats, then you might not catch what's going on. So always look at the rhythm strip. And for the type 2 second degree, Mobitz 2, it's going to be an intermittent complete blocked. So in that case, you're not going to have progressively slowed conduction. All you're going to see is intermittent absence of the QRS complex. And that's pretty obvious, but again, you have to look for it. If you don't look for it, then you might miss it. And third degree is going to be a complete AV block. So you have what's called dissociation between the atria and the ventricles. The P waves and the QRS waves are independent of each other, and they each have their own rates. So the easiest thing to do is find the QRS complexes, see what that rate is, and then look for the P waves. Is there a P wave kind of intermittently throughout the rhythm strip, going at its own rate? You might see it at the end of a T wave. Inside a QRS complex, you might see two P waves in between QRS complexes. So these can kind of confuse people. They still confuse me from time to time if I'm not really thinking about a third degree block. But once you start to understand what they look like, then it becomes easier. So let's go through some 12-lead EKGs. So for this, this is an example of first degree AV block, and you'll see that it's a normal 12-lead EKG, but they also have three different rhythm strips, V1, 2, and V5. So if you remember, pause it if you want, what a first degree AV block is. That simply means that the PR interval is greater than 200. So the easiest way that I do it is look at lead 2, the rhythm strip in lead 2. So you can see a nice R wave, you see the T wave, and then you see the P wave, and you see a long interval between the next QRS complex. So that, and then what you should do before just automatically saying it's first degree is go through the whole rhythm strip, and you can see that the PR interval does not change. There's no dropped QRS, so you know this is a first degree AV block. And you can automatically tell, you don't even have to count, that the PR interval is greater than one large block. So now for Mobitz blocks, there's two types. The first type, like I said, is the one where you have an increasing PR interval and then a dropped QRS. So look at the first picture on top, start all the way at the left. You see the PR interval, QRS-T. Then you see the next P wave, and the PR interval is much longer than the first one. So then you move to the third one, and you see that it's continuing to increase in duration of the interval. And then the next one, you see that it's missing a QRS complex. You see the T, then you see the P wave, then you see nothing, then you see another P wave. So that is an example of Mobitz type 1 or type 1 second degree AV block. The bottom one shows Mobitz 2, which has the intermittently dropped QRS without warning. So you look the PR interval, there's no blocks on here, but it does look prolonged, but the prolongation doesn't change over time until you get to the point where there's no QRS complex. So people mix these up all the time. I still have to think about it, especially if it's on an exam. You don't want to mix it up. They're really easy to get right once you realize it, so try to get them in your head however you can. But I'll say it again, Mobitz type 1, the increasing PR interval with then a dropped QRS compared to Mobitz 2, which has a normal stable PR interval, can be prolonged but stable, followed by a dropped QRS complex. And normally I will say there's a pattern. So there might be 4 beats to every dropped QRS. And if you want, you can look in a cardiology textbook, or Harrison's, I think, explains it as well. And for third degree, this is the one that's confusing. Let's look at the rhythm strip, which shows V1 on the bottom. You can see that the QRS complexes are very slow, which in the first lecture I talk about how you have the overdrive suppression. So if you have a complete AV block, the ventricle pacing kicks in by itself, and that's very slow, 20 to 40. So that looks about right. And then you have these faster P waves, which actually look biphasic, and I'm going to talk about that later. But you can see that the rate of the atrial beats are much faster, and you can see that there's 2 or 3 in between each QRS complex. They're marching along at their own pace, so this is known as dissociation between the atria and the ventricles. So the next type of block is a little bit more distal in the bundle branches. So let me just say a block is conduction that's inhibited from continuing down a certain path, and what happens is the block delays depolarization, and the pathway that's not blocked is depolarized rapidly, while the blocked pathway, the conduction has to slowly creep through the myocardium until it gets past the block. Think of it kind of like like it's stuck in traffic. The cars move slowly, and then once you get past the block, you're able to speed up again. So to give an example, if you have a right bundle branch block, what happens is you have left ventricular depolarization prior to right ventricular depolarization, and then the right ventricle depolarizes once it's past the block. Normally they should conduct simultaneously. And I kind of explained all that together already. So what happens is for both of these blocks normally is that you have a widened QRS because it takes a long time for both of the ventricles to depolarize. But the morphology will change based on if it's a right or a left bundle branch, if it's a hemiblock, like if it's only the left anterior or posterior fascicles. So there's a lot of combinations. So when you are looking at an EKG for a potential bundle branch block, you want to look at V1 and V2 as well as V5 and V6, because V1 and V2, as hopefully you know, are camera angles to the right side of the heart, while V5 and V6 are more towards the left side of the heart. And again, this is simple, but ventricular depolarization is the QRS complex. Normally a QRS complex is less than 120 milliseconds. Talked about that already. If you happen to have a normal QRS duration with a bundle branch pattern, which I'm going to show you in a second, that's known as an incomplete bundle branch block. So to think about the physiology behind this, if you have a right bundle, then the left ventricle depolarizes first and then the right, and vice versa. If you have a left bundle branch block, then the right side depolarizes first and then the left ventricle will eventually depolarize. So here's an example looking at V1 of a right bundle branch block. You can see that the QRS duration is prolonged, but it doesn't look normal. So I kind of wrote the steps on the side. Is it a wide QRS? Yes, but does it look normal? No. So you know that it's not, you know that something's going on that is most likely abnormal. So it doesn't look normal. So what you want to do is kind of get this picture stuck in your head forever, because this is always what a right bundle branch block is going to look like in the V1 and V2 areas. So since this is a right bundle, as I just said, the left ventricle depolarizes first. So the first R wave is the left ventricle, and then you see what looks like the downward area followed by another upward spike, which is known as R prime, and that would be when the right bundle, when the right ventricle depolarizes. So remember, the right bundle is slowed, so it takes a while. So the left ventricle followed by the right ventricle, and this is R and then R prime. And this is known as, some people call it bunny ears or rabbit ears, however you want to remember this. If you look in V1, V2 and see this, that's a right bundle. If you see this pattern in 5 and 6, then that's a hint that maybe there's a left bundle branch block going on. But get this picture stuck in your head, because this is the image you'll see on an exam for a right bundle branch block. For a left bundle, again, the duration is going to be greater than 120, but now it's going to look a little bit different. So the two things you want to look for is a dominant S wave in V1. You sometimes see the R and R prime at the tip of the S wave, but not necessarily. The other thing is it could be a monophasic R wave, but you can see rabbit ears as well in V5 and V6, or one in AVL, because those are all the lateral leads. The major thing you want to look for, though, and the thing that's going to stand out to you, is what this EKG shows in V1 and 2, which is the dominant S wave. And I put a little clinical fact in here that if you've seen a patient for a while and they've had a normal EKG and all of a sudden you see a left bundle branch block, it's a medical emergency, and it's pretty much an equivalent to acute coronary syndrome. So you might not see an ST elevated MI, which I'm going to go into later in this podcast. You might only see a new left bundle, and that's an emergency, unlike a right bundle, which people can live with for a long time, be asymptomatic. If they become symptomatic, then you kind of have to start thinking if that's the underlying disease that's causing them to be symptomatic. But a left bundle is serious, so remember that as well. And that's all I'm going to say about AV blocks and bundle branch blocks. So now I'm going to talk about ischemic changes. So a little bit of background on myocardial infarction. So, excuse me, as you know, the coronary arteries supply the heart with blood. It removes metabolic can't think of the word. Removes metabolic toxins and byproducts. So in the case of a myocardial infarction, what happens and what the underlying pathology is that you have atheromatous plaque, the fatty plaque, which is beneath the intimal layer. It's not in the lumen. It's beneath the intimal layer of the coronary artery. That can end up rupturing if it's a weak plaque or an unstable plaque, and that leads to the exposure of subendothelial collagen, activation of the clotting cascade, von Willebrand factor, and all that stuff, and you get thrombus formation. Now, thrombus formation can be a subtotal occlusion, or it can be a total occlusion of the vessel. If it's subtotal, then you get what's known as unstable angina or a non-STEMI. If it's total, then that's what a STEMI is, a ST elevated MI. And that's different from someone who has stable angina. That's when they have the atheromatous plaque that causes an increase in oxygen demand when they exercise. So that's very different. But in this case, you have thrombus formation from unstable plaque rupture. So what happens after this thrombus formation is that initially you get ischemia because you have decreased blood flow. Then you get injury, and then you get eventual necrosis and cell death. So keep that pathway in mind as we go through this. So, and that's also why times to reperfusion, whether it's through someone having a cardiac catheterization or TPA, the time is very important, very similarly to a stroke. So to rule out ACS, and I'll say ACS, acute coronary syndrome, is an umbrella term for unstable angina, non-STEMI, and STEMI. And you can rule this out pretty quickly with a 12-lead EKG and cardiac enzymes. Now, you want to do serial enzymes over pretty much 24 hours. Every 6 or 8 hours, you can repeat the cardiac enzymes and look for trending. I also put in the other things you want to look for, like new conduction abnormalities, any ST changes or T wave inversions or peak T waves, Q waves. And I already talked about non-STEMI versus STEMI, so you can reread that if you want. And again, this is from the first lecture. This is super important when it comes to STEMIs, or ACS, I should say, because if you see any changes to the ST segment, like ST depression or ST elevation, you want to be able to pinpoint or hypothesize which vessel is involved. So when the person gets a coronary catheterization, it's easier for the interventional cardiologist to know where to start looking. So 1, AVL, V5, and V6 are all left lateral, so that's going to be the left circumflex. 2, 3, AVF are all inferior, so that's going to be the right coronary artery, which supplies the apex of the heart. The LAD supplies both the septal regions and the anterior regions. So that's super important. And so back to MIs and kind of the pathway: ischemia to injury to necrosis. Ischemia is the first thing that happens because of the reduced blood supply, and this is seen on an EKG very early as inverted T waves, which are symmetrical. And I wrote it's the first sign of impending doom. Maybe a little overdramatic, but it is important to recognize these inverted T waves, especially in a patient who presents with chest pain. And the best place to check for T waves are going to be in the precordial leads, V1 through V6, because those are looking right at the ventricle. The second thing that happens after ischemia from decreased blood flow is you get injury to the myocardium, and this is when you'll see ST elevations. And it's the earliest sign of infarction, so that's different from having ischemic changes in step 1. And finally, if the person's not able to be treated or the infarction and injury is too severe, you get necrosis, and that's when you see Q waves. So that's why old EKGs are important to have when analyzing a patient, because you can tell if they have Q waves or not. And remember, Q waves, if you think about the QRS complex, it's the first part. So you can have insignificant Q waves, but they are also a marker of necrosis. So if a patient says they had inferior MI, 10 years ago, then the EKG might show Q waves in 2-3 AVF. If you see that they've never had an MI before and now they have ST elevation with Q waves, this is sometimes called a Q wave versus non-Q wave infarct. I think they're getting away from that terminology, but still important to know. So if you have a significant Q wave, it will be at least 0.4 seconds wide, which is one small square, or a third of the entire QRS amplitude from top to bottom. So if you see a tiny little Q wave, you want to kind of figure out if you think this is significant or not before you go tell your attending. And ST depression, like I already said, is subendothelial or subendocardial infarction. It doesn't extend through the full thickness of the ventricular wall like a true MI or a STEMI does. And here's a good progression of what a STEMI would look like from earliest to the very end. So you see on top is normal. The first thing, again, ischemia, you'll see T wave changes, in this case peak T waves. Following that, you'll see injury from the ischemia, and that is the ST segment elevation. Some people will say it's known as tombstoning. If you look at the picture on the right of the ST segment elevation, you'll see it kind of looks like a tombstoning, and that just means that the patient's in trouble, because there are other causes of ST elevation like pericarditis or variant angina. So tombstoning is different. And then further down, you can follow the progression is necrosis, and that's when you'll see the Q wave really become significant. And that occurs later. So here's an example. Again, you want to always go through your same system of looking at EKG, starting with the rate and rhythm. But the thing that will stand out, and I'll go to first because we're talking about infarction, are the ST changes. And if you look in V2, V3, V4, V5, V6, you'll see that there's ST elevation. The other thing you'll notice if you look carefully is that in leads 2, 3, and AVF, there's actually ST depression. And these, in the setting of a STEMI, the depression is known as reciprocal changes, and that's just based on how the leads oppose each other. So if you go back, if this is your patient and you see that the ST elevation is in 2, 3, 4, you know that's anterior. So the involved artery would most likely be the left anterior descending artery. However, also in lead 1 and AVL, you see that there's ST elevations. So not only this is an anterior STEMI, it's what's known as an anterior lateral STEMI. So the left circumflex is involved as well as the left anterior descending. So this would be known as a two-vessel disease. Here's another example. If you look through this, you'll see in leads 2, 3, and AVF, there's ST depression instead of elevation. So this is what's known just as ST depression, and this might be found in a patient with unstable angina who's presenting with chest pain, or someone who's asymptomatic who's being worked up for chest pain during a exercise or a chemical stress test. You can induce these changes, and that's indication for catheterization. The other thing that's important, and I should say, so if it's 2-3 AVF, you know that this is inferior apical, so it's going to be the right coronary artery. So when the right coronary artery is involved, what you want to check for is any type of block. So whether, now that you know the different types of blocks, you want to check for all the signs of those, whether it's first, second, or third degree, because both the SA nodal artery and the AV nodal artery both come off of the right coronary artery. But if you look at the rhythm strip below, it looks like it's a regular sinus rhythm. So next, I want to talk about atrial and ventricular abnormalities. So I'll start with the atria and what a normal P wave will look like. As you know, a P wave indicates atrial depolarization, and leads 2 and V1 will have the greatest views because they're looking right at the atrium. So atrial abnormalities or atrial enlargement are the terms that are used. You don't really want to use hypertrophy or dilation because you don't really know unless you have an echocardiogram, which is an ultrasound of the heart. So a normal P wave is going to be smooth and symmetrical, like the picture on the left. I wrote monophonic. I think my computer changed it. It should be monophasic in lead 2, which is what you see, and biphasic in lead 1, or V1, excuse me. But again, you want these to be symmetrical. If it's biphasic, but the initial component or the terminal component is higher or lower than the other, then something's going on. So symmetrical is important. They're going to be upright in 1 and 2 and inverted in AVR. If you look at the duration, it should be under 120 milliseconds, and the amplitude in the limb leads, like 1 and 2, should be less than 2.5 millimeters or less than 1.5 millimeters in the precordial leads. So if there's a right atrial abnormality, you can look in either lead 2 or V1. The width will be under 120 milliseconds for both, but now the height is going to be greater than 2.5 millimeters in lead 2. So that's one indication of a right atrial abnormality. The second thing to look for is in V1 at that biphasic wave. If you look in the bottom picture, you can see the P wave is biphasic. There's first the initial component that's a positive deflection followed by a smaller negative deflection. If this was a normal symmetrical biphasic P wave in V1, then they should be the same. But clearly the initial component has a larger component than the terminal component. So this would be classified as a right atrial abnormality. For a left atrial abnormality, now the width is going to be greater than 120 milliseconds, but there's going to be a normal height. And when it gets to that length, or width I should say, sometimes you can see notching. You might not always see it, but you can see a notching, and the picture does a good job of showing what that looks like. Again, you can look in V1 at the biphasic wave, but now if you see there's a greater negative deflection in the terminal component than the initial component, so that would classify for a left atrial abnormality. And lastly, we're going to talk about ventricular abnormalities. So in this case, most of the time it's going to either be dilation or hypertrophy. Again, you would need an echocardiogram to confirm your thoughts from what the EKG shows. But in this case, you always want to run down V1 through V6 to check for any potential abnormalities. I talked in the first lecture about having good R wave progression. So this is where where that will come into play. So right ventricular hypertrophy is when you have a large R wave in V1 that progressively gets smaller. So that's the opposite of good R wave progression. And this can sometimes create a right axis deviation. Now you know that right axis deviation will be negative in lead 1 and positive in AVF. And so that's really it for that. There's a lot of different criteria for right and left ventricular hypertrophy. I suggest you look them up if you're really curious. And the last one would be left ventricular hypertrophy, where you have large S waves in V1 through V3 and large R waves in V4 through V6. So one of the criteria wants you to add the S wave in V1 and the R wave in V5. If that is greater than 35 millimeters, remember each small box is 5 millimeters, then that classifies as LVH. But I will warn you that left ventricular hypertrophy has a lot of different criteria, and it can get confusing. Even cardiologists I know don't memorize all of them, so if you want to just take a look online to see what they include, then that might be helpful if you're really interested. And again, for left ventricular hypertrophy, you're going to see left axis deviation, which would be positive in lead 1, negative in lead 2, and negative in AVF. So here's what right ventricular hypertrophy would look like if you see there's really powerful R waves in V1, 2, 3, and then they kind of subside as they get further lateral towards V6. The other thing that you want to look for is to see if there's any right axis deviation, and there is in fact right axis deviation. If you look at lead 1, then the S wave is greater than the R wave, but then the upward deflections in 2 and AVF are upward, so that's right axis deviation along with right ventricular hypertrophy. This EKG shows left ventricular hypertrophy. You can see pretty tremendous S waves, especially in V2. So if you add the S waves plus the R waves in V5 and V6, that definitely is greater than 35 millimeters. You almost have greater than 35 just in V2 itself. So that's my favorite criteria for left ventricular hypertrophy. And that's it. So a lot quicker than the first lecture. Hope you enjoyed them. If you have any questions or comments or suggestions, please feel free to email me, dlewis@tcmc.edu. Thank you.